We're now going to discuss the quantitative assessment of the right ventricle. You may recall that when we went over the basic cardiovascular talk, we went over the qualitative assessment of the right ventricle. We talked about the assessment of RV size, specifically in relation to LV size. We talked about RV function, which is the evaluation of TAPSE, which is actually a quantitative modality, but we did talk about it in the basic talk. We talked about the assessment of septal shape and septal motion. And finally, IVC size and IVC variability and how it relates to RV pressure dynamics. When we talk about the quantitative assessment of RV, there's really two sort of categories that we look at. We look at RV systolic function. I'm going to review one more time the TAPSE and then a new modality that we didn't discuss thus far called the tricuspid angular systolic velocity, or the S prime. And we'll also talk about how to assess RV and PA pressure dimensions, or pressure dynamics rather, by looking at TR jet velocity and RVOT or PA acceleration time. So let's start by reviewing TAPSE, which, like I said, is a quantitative modality, but we did discuss it in the basic talk. So as you recall, when the RV contracts, because it doesn't normally own the septum, and it's a relatively weak wall when compared to the LV, it has relatively few dimensions, planes, within which it can actually make its chamber smaller. So the primary plane, or the primary axis in which the RV gets smaller, is by shortening. So when the RV contracts in systole, the RV shortens. And when the RV shortens, the tricuspid annulus attached to the free wall moves up towards the apex, and then diastole it moves down. So when we talked about assessing RV function, we talked about how measuring the excursion of tricuspid angular motion in systole, called the TAPSE, or tricuspid angular plane systolic excursion, is a pretty good indicator of RV function, assuming there's no significant wall motion, focal wall motion abnormality. So what we're looking at is we're measuring the degree of RV shortening. And remember, we talked about how the normal range is anywhere between about 1.6 and 2.2. Here again is an illustration of RV contraction, and you can see that in systole, the RV shortens. As the RV shortens, you can see that the tricuspid annulus here moves up towards the apex, and in diastole it moves down. So what we can do is actually put M mode down through the tricuspid annulus there to look and see how much excursion there is up and down. So again, remember that in order to get the most accurate assessment of TAPSE, you have to be as on axis as possible. Specifically, you want the angle of the septum to be as vertical as possible, so that when the tricuspid annulus bounces up and down, it moves almost parallel, as close to parallel to that M mode line as possible. So you get the most accurate assessment of tricuspid angular excursion. And you can see that as you put M mode down through the tricuspid annulus, you can see that annulus moving up and down in systole and diastole. Again, if we look back at the structure that the M mode line goes through, it goes through the LV apex, the LV chamber, the septum, the RV chamber, and finally the tricuspid annulus, which is what we see here: LV apex, LV chamber, septum, RV chamber, and finally the tricuspid annulus. And you can see it bouncing up and down. So y-axis is movement in centimeters, x-axis is time in milliseconds. So you can see it moving up and down over time. This is systole, this is diastole. If we measure this, we can see here in the normal RV, the TAPSE is about 2. In RV systolic dysfunction, you can see that that degree of motion is not all that significant. So a TAPSE of under 1 here. So normal RV, a dysfunctional RV. So that's one way. Another way, which is out there, is not looking at the degree of motion or the amount of excursion, but you're actually looking at the velocity of angular movement in systole. There are some data to suggest that this may be a more accurate or more representative indicator of RV function than just the excursion, the degree of excursion, the actual velocity of angular movement. And so if we're looking at degree of excursion, we use M mode. If we're trying to look at velocity, we use Doppler. Because we're trying to look at a specific point, we use pulse wave Doppler. But we actually use a subtype of pulse wave Doppler called tissue Doppler. So tissue Doppler is actually optimized in the size of the gate and other settings in order to visualize solid tissue or soft tissue instead of visualizing movement of blood, red blood cells. So what we're doing is we're using tissue Doppler to look at the velocity of angular movement. Okay, so what we do is we get into our apical 4-chamber view and we turn on pulse wave Doppler. And again, you want to make sure that you're in as on axis of a apical 4-chamber view as possible, so that when that mitral or that tricuspid annulus is moving up and down, it's moving as parallel to the velocity line as possible. So again, because this is a Doppler modality, theta angle is very important. So you want that tricuspid angular movement to be as parallel with that Doppler line as possible. This is even more important with S prime or TASV than it is with TAPSE. So you line that up and then put your sampling volume right in the middle of the tricuspid annulus there, that meaty part of the tricuspid annulus, and you hit start. And what you're going to get is a waveform that looks like this. So this is velocity again on the y-axis, time on the x-axis. You can see that in systole, the mitral annulus moves, or tricuspid annulus rather, moves up, and then diastole moves down. So this is velocity over time. So this is a curve of the instantaneous velocities over time in systole and in diastole. So what we basically do is once we get this waveform, we freeze it. And like I mentioned before, any quantitative analysis should be done in expiration, because again, we're typically measuring things and we're looking to see how those things change over time. And we want to make sure, like with an intervention, so we want to make sure that if we're measuring from pre-intervention to post-intervention, we're doing it in the same part of the respiratory cycle as possible, because there could be respiratory variation of all these quantitative indicators, including your TASV or your S prime. So you freeze it in expiration, then you turn on a caliper, and you basically measure that velocity. This is the S prime velocity moving up, and diastolic velocity is moving down. So we measure the systolic velocities here. An S prime velocity of under 10.5 or 11, depending on the study you look at, is indicative of RV systolic dysfunction. So this is what you're going for. You're looking for evidence of RV systolic dysfunction. And this number correlates with radionuclide imaging and radionuclide imaging derived ejection fractions of the RV. So an S prime velocity of less than 10.5 or less than 11 indicates RV dysfunction. Okay. So another modality to get an idea of what the RV systolic function is. Okay. So that's RV function. We can then move on to RV pressure estimation. So why is this important in critical care? This becomes important when you're dealing with a patient that has RV strain, for example, RV pressure overload and shock. So for example, you take the classic massive PE patient. They have RV pressure overload, they have shock, and you're doing things to try to reduce the RV afterload in order to improve RV function and improve cardiac output. So for example, you're pushing TPA, or you may be starting inhaled Flolan to reduce pulmonary vascular resistance, and you're trying to see quantitatively if your therapies are having an effect and the magnitude of the effects. Okay, that's the most common reason we would want to measure pressures in the ICU setting. There are some data that suggests that in patients with ARDS, for example, if they have new onset cor pulmonale, that is a negative prognostic indicator. So that may be a tool that you can use or a data point you can use to help you, prognosticate these kind of patients. But more often than not, we're doing it to figure out how well our RV pressure overload therapy is working. Okay, so typically what you would do in this setting, you get this patient with RV pressure overload and shock. You start your intervention, you push your TPA, you start your inhaled Flolan. And then what you would do is pre-intervention, you would measure the RV pressures, and you would also measure the stroke volume, the LV stroke volume. And what you would want to happen when you give your intervention is you would want the RV pressures to come down, and you would want your stroke volume to go up. So what you're doing is you're doing serial measurements of your right-sided pressures and your your stroke volume. So that's one of the most common ways you would do this. As you know, echo-derived RV and PA pressure measurements tend to be underestimates when compared with right heart cath. So they are not super accurate. So you're not using this to diagnose pulmonary hypertension. You shouldn't really even use this to see how someone's pulmonary hypertension when compared with a previous echo has progressed or improved, compared with the last study. Really what you're doing is you're trying to see acutely what's happening to these measurements, these pressure estimations, as you give an intervention, whether it be diuresis, whether it be a pulmonary vasodilator, or what have you. Okay, so there's two methods that are most commonly used in the critical care setting to estimate right-sided pressures. There is the TR jet velocity method, and then there is the RVOT or the PA acceleration time method. I'm going to talk about both of these. Okay, so first let's talk about the TR jet velocity method. So what we are doing is we are measuring the peak velocity of tricuspid regurg, and we're using that to estimate the systolic PA pressure or the RV systolic pressure. Okay. Now this is based on the Bernoulli principle, and I'm going to talk a little bit about that in the next couple slides. But first, let's talk about how to do it. So the first thing you want to do is you want to find TR. And remember we talked about there are three views where identifying TR is optimal. One is in the peristernal long axis view, in the downward angled view, which is called the RV inflow view. So you get into your peristernal long axis view and the angle downward. In the peristernal short axis view, you would angle upward from the mid-papillary level. You would angle anteriorly. And then when you're at the level of the aortic annulus, you can see the tricuspid valve there, just a screen left of the aortic valve. And then finally, of course, there's the apical four-chamber view where you see the tricuspid valve there. So what you would do in each of these views, you would put color over the tricuspid valve and over the right atrium, and you would try to identify a TR jet. When you identify the TR jet, just very subtly angle anteriorly and posteriorly to make sure you're capturing the brightest and the widest jet you can, the color jet that you can. Okay. And like I said, you just do it in all of these views, and the view that gives you the best color jet and the best theta angle, that's the one that you're going to use. Okay. So you find your color jet, and you're going to use continuous wave Doppler. Because here we're interested in maximum or peak velocities. So remember, if we're interested in peak velocities or maximum velocities, you use continuous wave Doppler. So we identify the TR with color, then we put continuous wave Doppler down that color jet. Okay, so here are the three views that I just talked about. Here's the peristernal long axis view, the downward angled or the RV inflow view. So you get into your normal peristernal long axis view and you angle down or angle posteriorly, and then you'll bring in the tricuspid valve here. So this is right atrium, this is right ventricle, and you would put color over the tricuspid valve and over the right atrium. The second view, this is your peristernal short axis view, angling upward or angling anteriorly to the level of the aortic annulus. Just to the left of that is going to be your tricuspid valve here. So what you do is you put color over the tricuspid valve and over the right atrium here. And finally, your apical four-chamber view, of course, your tricuspid valve is here. So you would put color over the tricuspid valve and over the right atrium to find the color jet. And like I said, once you find the color jet, just very subtly angle anteriorly and posteriorly to try to get the brightest, biggest jet that you can, because that's the one that you want to sample the velocity of. Okay, so put color, so find your TR jet, put color over it, find the TR jet, find the brightest, biggest TR jet you can find, turn on continuous wave Doppler. Okay, and then what you're going to do is you're going to align that beam to be as parallel as possible with the color jet. So again, you're trying to make that theta angle between color jet direction and Doppler direction to be as small as possible. Okay, and you can tilt your view here to try and line that up as best as possible. Okay, so put your color jet on, put your continuous wave Doppler through that color jet. And then you hit Doppler or you hit start, depending on which machine you're using. And what you're going to get is a waveform that looks like this. So in this view, in all the views, TR is going down. So it's going from the right ventricle into the right atrium. So the velocities that we're interested in are the ones that are going down. So again, velocity on the y-axis, time on the x-axis. These are your velocity time tracings of tricuspid regurg jet. You want to freeze it, again, in expiration, because this is a quantitative measurement. You want to hit calc, select TV for tricuspid valve, and then select TR max for tricuspid regurg max velocity. When you select that, it's going to give you a crosshairs with a line. And what you want to do is you want to bring that crosshairs to the bottom of your waveform. Okay. Now I want you to look at this waveform closely. Notice how it is a parabolic shaped waveform. And this is because this is a waveform that is generated by the RV contracting. So what you have is you have a gradual increase in velocity to a rounded bottom and an almost symmetric deceleration to 0. Okay, so this is the shape of a waveform that you're looking for with a TR jet. It should be parabolic in shape. It should be rounded at the bottom. Okay, if you see a waveform that's squared off at the bottom or scooped out or pointy at the bottom, what's happening is your theta angle between TR jet direction and Doppler direction is off. And sometimes there's nothing you can do about it, but that means your theta angle is off. And remember, if your theta angle is too large, what it's going to do is result in an underestimate of velocities. So you can imagine, instead of seeing this rounded bottom here, you're seeing a flat bottom or a pointed, sort of bottom or a scooped out bottom here. You can imagine that your velocity that you measure, instead of being down here, will be up here. So it'll be an underestimate. Okay. So remember, this is the shape of the waveform you're going for. Oftentimes, because of the direction of the TR jet, you won't be able to get this. But if you don't, just remember that this is going to result, if it's not this shape, your measurement is going to be an underestimate. So just remember that. Okay. So again, parabolic shape is what you're going for. And you want to measure the peak velocity here. Okay. When you measure that velocity, I'm just going to correlate with that y-axis there. This is going to give you a bunch of numbers. It's going to give you first the actual velocity in centimeters per second. Okay. And then it's going to calculate what's called the pressure gradient between the right ventricle and right atrium. Okay. And the way it determines that is by using the Bernoulli equation. The Bernoulli equation is based on the Bernoulli principle, which is a principle that explains the movement of fluid between two chambers. And it explains that the movement of fluid between two chambers is directly proportional to the pressure gradient between those two chambers. So if you know the velocity of a fluid moving from one chamber to another, you can calculate, using the Bernoulli equation, the pressure gradient between the two. Now, this is a very simplified version of the Bernoulli equation. The one that the aviation guys use is much more complicated, but we're just dumb doctors, so we use a simplified version of it. And the simplified version says that if you take the velocity, in this case of the TR jet, and you square it and multiply it by 4, so TR velocity squared times 4, that will give you the pressure gradient between the chamber driving the flow and the chamber receiving the flow. So in this case, the gradient between the right ventricle and the right atrium. So 4 TR jet velocity squared, 4 times TR jet velocity squared gives you the pressure gradient between RV and RA. Okay. If you take that pressure gradient and you add it to your right atrial pressure, that will give you the RV systolic pressure, which is about equivalent to the PA systolic pressure. Okay. Now, how do you calculate right atrial pressure? So that, at least non-invasively, is based on the assessment of IVC diameter and IVC collapsibility. If you have a central line in place and you're at a place that measures CVP, you can use the CVP number as long as the tip of the catheter is at or near the cavo-atrial junction and it's properly zeroed and so on. But I mean, we don't do that anymore, so you're less likely to find that. You can use a non-invasive method looking at IVC diameter and IVC collapsibility. Now, this is based on how the echo folks estimate right atrial pressure using IVC size and inspiratory collapse. So we look at the size, we look at how much forced inspiratory collapse there is with the sniff, and then we use that to estimate your right atrial pressure. So the arbitrary size that they use is 2 or 2.1 centimeters. Okay, if your IVC is small, so under 2.1 centimeters, and you have a lot of collapse, more than 50% collapse with a sniff, that suggests that your right atrial pressure is low, somewhere estimated between 0 and 5 millimeters of mercury. If your IVC is small, less than 2.1, but there's less than 50% collapse with a sniff, then your right atrial pressure is somewhere between 5 and 10. If your IVC is big, bigger than 2.1 centimeters, and you have a lot of collapse with a sniff, then it's somewhere between 10 and 15. If the IVC is big and doesn't collapse all that much, then the estimated right atrial pressure is high, above 15 estimated. Okay. So then what you would do is you would take that number and add it to your pressure gradient, and that will give you a fairly, at least reproducible estimate of your right ventricular or your PA systolic pressure. Okay. But remember, in order to use IVC diameter and collapsibility to estimate right atrial pressure, you have to be negative pressure breathing. So you cannot be on positive pressure, whether it be non-invasive positive pressure ventilation or intubated on the vent. So you have to be negative pressure breathing, and you have to be cooperative. Your patient has to be cooperative because they have to be able to do a sniff. Okay. If you don't meet these criteria, then just follow the pressure gradient. And it's okay to just follow the pressure gradient because, again, what we're doing is we're not so much interested in what the RV systolic pressure is. We're more interested in what that estimation does, what that number does after we do our intervention. So we can just follow the pressure gradient in that case. Okay. So what about the TR jet velocity as far as advantages and disadvantages? So this is your tried and true method. This method has been there for a long time. It's been studied, it's been standardized. So it's the go-to method for estimating, non-invasively estimating right ventricular pressures. It's fairly easy to do, but the downside is you have to have not only TR, but you have to have a usable TR jet. So you have to have a TR jet that is big enough, that's long-lasting enough, and that is directed in such a way that you can line up your Doppler beam to be as parallel with it as possible. Okay. If you don't have these things, obviously you can't use a TR jet velocity method to estimate right-sided pressures. So what can you use? You can use this method. So this is called the RVOT, or the PA acceleration time method. And all this method requires is that you have anterograde flow of blood through the RVOT in systole. So hopefully every patient you're echoing has cardiac output. So that's all you really need to do this method. And you have to be able to find the view. Okay. But let's talk about the principle behind it first. So the principle behind this is that if you look at a patient with normal PA pressure, so that means a normal RV and a low afterload pulmonary arterial system, so low afterload, low resistance, normal RV. When you see blood being shot out of the RV through the RVOT, if you looked at the VTI, or the velocity time curve of normal PA pressures, what it would look like is something like this. So this looks like the TR jet, right? Fairly symmetric, fairly rounded bottom, okay? Gradual acceleration to peak, gradual deceleration, okay? That changes when you start to develop elevated right-sided pressure. So once you develop a hypertrophied LV, or more importantly, high downstream afterload, so elevated pulmonary vascular resistance, what will happen is, instead of this nice parabolic shape like the TR jet, what you'll see is something like this. And this looks familiar, right? This looks more like the left ventricular velocity time curve. So notice what happened is acceleration to peak is much faster. And you have sort of a, sharp bottom there, knife-shaped bottom. So this looks just like the left ventricular velocity time curve. Okay. So what we're seeing is the time it takes to go from zero velocity to peak velocity is much shorter when you have elevated PA pressures or high downstream afterload than when you have normal downstream afterload. Okay. So how do you measure this? So what you do is you get into this view. So this is your RVOT view in the short axis. So you get into your parasternal short or your subcostal short, and you angle up to the level of the pulmonic valve. Okay. Here's a pulmonic valve here. So you basically will go to the aortic annulus and angle even higher to bring in the pulmonic valve. You will turn on pulsed wave Doppler. just like you would do for your left ventricular velocity time measurement. You want to put your sampling volume just above the pulmonic valve, okay? And you want to line this up to be as parallel with the direction of blood flow as possible. So again, blood is going to go from RVOT down through the PA. So you want to line that up as parallel as possible, sampling volume just above the pulmonic valve, and you hit start, okay? So this is a normal curve, and this is the curve that you would see with elevated PA pressures, okay? Now, what we're interested in is not the VTI itself, but we're interested in the time it takes to go from zero velocity to peak velocity, or what's called the RVOT, or the PA acceleration time, okay? So what you would do is you would freeze this in expiration. You would want to select PA in your calc package, select PA, and then go to AT for acceleration time. And it's going to give you two lines here. You put the first line at zero velocity and the second line at your peak. And that will give you the acceleration time, or the AT. Okay. Now, what do you do with that information? So there are two sets of equations out there that correlate acceleration time with PA pressures. The first correlates it with systolic PA pressure, but when I look at this, I see this log thing, and that scares me, and that scared most clinicians. So really, this equation isn't really used all that much. It's not all that well validated. The equations that we use are actually these, the ones that correlate acceleration time with mean PA pressure, okay? So you look at your acceleration time, and if your acceleration time is greater than 120, and the normal acceleration time is above 130. So if acceleration time is greater than or equal to, I should say, 120, use the first equation. You take your acceleration time, multiply it by 0.45, and you subtract that product from 79. And that will give you a fair estimation of your mean PA pressure. Okay? If your acceleration time is short, so under 120, use the second equation. So 0.63 times the acceleration time, subtract that product from 90, and that will give you an estimation of your mean PA pressure. There's also a correction for heart rate. So if you're relatively bradycardic, under 70, or relatively tachycardic, under or over 100, take whatever number you got from one of these two equations, multiply by 75 and divide by the heart rate, and that will give you the heart rate corrected estimation for mean PA pressure. Okay. If you have questions, again, come find me or shoot me an email. Otherwise, I look forward to scanning with you.